All right, we've got a full agenda today. Go ahead and off. Hi, everybody. Welcome. My name is Jenny Sutcliffe. I'm a senior healthcare policy analyst in the Bureau of Equitable Health Systems at the New York City Department of Health. But during our coronavirus response, I've been leading the PPE, Personal Protective Equipment Task Force. I know that I've worked or emailed or communicated with many of you as we've sort of sought to distribute PPE, share guidance, best practices over the last few months. And so we're really pleased to be able to offer this webinar for everybody. Today we're going to be chatting about personal protective equipment, purchasing and capacity building. We've got a number of great experts that have joined us today. We have Mary Foote, who's a senior health security specialist in the Bureau of Healthcare Systems Readiness at the Department of Health. We have Dave Starr, who's our assistant commissioner for the emergency field operations. Jay Gormley is joining us from MJHS Health System, where he's the chief strategy officer, and then myself. We have, I wanted to sort of review a couple of the webinar objectives. The first is to provide a refresher on the use of PPE, including updated guidance on outpatient. We're going to chat a little bit about calculate burn rate and some considerations that you might want to think about as you think forward planning for calculating a burn rate for your different agencies and providers. We're going to share some considerations and best practices for purchasing PPE. We are going to offer, although we have already offered, a list of medical suppliers. And then I just wanted to highlight sort of the intended audience for this today is really agencies and providers with sort of limited experience purchasing that also have healthcare work staff who require PPE for interactions with clients, patients, or residents. I took a quick look and sort of thanks to everyone who registered and filled out some information that we asked as part of the registration. And it sounds like there's, potentially up to 500 of you on this webinar today, which is great. And registered, about a quarter of you indicated that you don't typically purchase PPE. So I think that this webinar will hopefully sort of really be the most helpful for you as you think through your long-term needs as we move into sort of a suppression phase of this crisis. And then 2/3 of you all indicated that you were able to purchase PPE within the last month. And so that's a great sign, right? I think we are all really encouraged that the supply chain is starting to bounce back, and Dave will chat a little bit more about that. But I thought that that was great to hear that so many of the different providers have had some success purchasing some PPE. And then in terms of the different sort of entities and audience that's listening in today, it looks like we have quite a good mix of social service agencies, community-based organizations, and outpatient healthcare providers. And, our hope is that there is some, there might be some new information here. This might be a bit of a refresher for those of you who are outpatient practices that have been ordering PPE forever. There might not be that many new pieces of information in here for you, but as we have sort of moved forward in this, in this crisis and moved into the phase of suppression, we really wanted to make sure that we were providing out and sort of able to share at least what we've learned about some best practices for purchasing and sort of put some of these tools and tips into your hands so that you can use them going forward. So our outline for today is to sort of chat about the guidance, a little bit on forward planning, calculating a burn rate, purchasing PPE, and then we're going to leave plenty of time for questions and discussions at the end. I think that you go ahead and any time sort of chat questions into the chat box and we'll answer as we go. And then for some that we think will be useful, we'll sort of save those either for the end or as we get to the end, you can sort of chime in with other questions. We're going to kick it off a little bit with a short overview of face coverings and the difference of face coverings versus PPE. A face covering can help prevent the spread of COVID-19. As you know, the governor has an executive order that individuals must be wearing face coverings when they leave the home and cannot maintain at least 6 feet of distance from others. A face covering can include anything that covers your nose and mouth, desk masks, scarf, bandanas. I myself do not sew, but my aunt does, and so she sent me a number of nice face coverings. When you're wearing a face covering, it's not, that's not a one-size-fits-all solution. It's still really important to practice healthy hand hygiene and physically distance yourself from others as much as possible. And then sort of underscore that face coverings do not protect the wearer, right? They're not considered PPE. Face coverings are for source control. And so they're not, something that we actually would recommend if you're working with a COVID positive patient. But they are very important as a big picture part of this response and mitigating transmission of the disease. And there are a number of different avenues that you can obtain face coverings. If you're a small business and you'd like to get free face coverings for your employees, you can go to newyorkcity.gov and search for free face coverings. And a small business in this case is considered to be a business of 100 employees or less. So that's a really good option that's sort of being provided by the small SPS, small business, something who's now their last part of their acronym is escaping me, but through the mayor's office. And if you're a community-based organization that contracts with the city, you should reach out to the agency with whom you contract to see if they have face coverings for you. So for example, if you have a contract with DOHMH, you're one of our supportive housing providers, or one of our, healthcare providers, you should reach out to us and see if we have face coverings available to you. And then lastly, if you're a faith-based institution or a community-based organization that's not contracted with the city, you can reach out to Kate Chance at the Community Affairs Unit, and her email is provided there. So, this is sort of, you may be able to get these materials for free if you fall into these different buckets. But again, I think that there really is sort of a surplus of face coverings available in communities, online, through response efforts. So hopefully that's a good, one of these pathways will work for you. The other sort of piece of information that I wanted to sort of provide at the beginning, and this is a little bit out of order, but it just sort of fit here, was information on reporting price gouging. So in early March, the New York City Department of Consumer and Worker Protection announced an emergency rule that price gouging is illegal for any personal or household good that's needed to prevent or limit the spread of coronavirus. And this includes things like cleaning products, disinfectants, face masks, gloves, hand sanitizer. It also includes like tissues, paper towels. There's actually a special section for toilet paper, which I learned today. And you can report that price gouging through 311. And if you go to the 311 page, you can follow, or I've hyperlinked here, there's actually a form that you can fill out to report overcharging of these sorts of things due to coronavirus. And overcharging is considered anything that is 10%, an increase of 10% of the cost. So that's sort of just another piece of information that I wanted to share out to you all. All right, so I am going to hand it on over to Mary, who's going to chat about our PPE recommendations and guidance. Mary, take it away.
Okay, thank you so much. So my name is Dr. Mary Foote. I've been working on infection control related issues and healthcare preparedness for emerging infectious diseases for going on 5 years now. So thank you for inviting me. Next slide. So first, I just wanted to give a quick review of COVID-19 and the major routes of transmission and associated PPE that goes along with that. So droplets are still considered to be the primary mode of transmission of COVID-19. And as a means of protecting against droplet transmission, we recommend the use of face masks and eye protection to protect your mouth and your eye mucosal membranes from contamination. And what we call opportunistic aerosol spread is theoretically possible and was potentially shown in other MERS and SARS similar outbreaks in the hospital setting during aerosol generating procedures. And so for that reason, in those circumstances, performing that type of procedure, we recommend to wear a fit-tested N95 respirator, higher level of protection. And there's been some question about how big of a role contact or fomite transmission might play, but it is thought to, still be a risk that we should be protected against, especially in healthcare environments. So, which is why we recommend the use of gowns and gloves when in at least direct physical contact with a suspect or confirmed COVID-19 patients. And that's also why it's still really important to be very rigorous with your environmental cleaning and disinfecting protocols. Next slide. So I just want to give a quick review. This is an outpatient PPE guidance that was posted on our website a couple weeks ago that I wanted to review. So looking at a couple different scenarios. So for the first scenario, which is when caring for possible or confirmed patients with possible or confirmed COVID-19, we recommend the following PPE, including mask, which would be a surgical or procedural, or the use of fit-tested N95s, particularly for aerosol generating procedures, are appropriate. And we do recommend eye protection with goggles or face shield. Isolation gown, again, that's still kind of under debate in the outpatient setting, but if you are in direct contact with a patient, we do recommend it. We recommend gloves and also patient source control. So the patient should always be wearing a face mask or face covering whenever possible. Next slide. So for the scenario when you are caring for patients without COVID-19 symptoms, so asymptomatic, there for other things, we have recently had an update from the CDC guidance about this type of scenario in areas with moderate transmission, which is where New York is right now. And so we have adjusted our recommendations to include for non-COVID type encounters to still wear a face mask. So physicians or clinicians should all be wearing a face mask and eye protection during any clinical encounter to protect against the potential for asymptomatic or pre-symptomatic transmission from a patient that may be carrying, maybe sort of a carrier of coronavirus but not be showing symptoms. And of course, throughout the facility and for any clinical encounter right now, we are recommending universal source control. That would include face masks for staff and face masks or cloth face coverings for others, including visitors, patients, or their caregivers. Next slide. So just to kind of talk through some of the rationale for these guidance. So these guidance are all in line with the CDC's guidance, and we just really want to reiterate, there's a high demand for N95 still, and out of fear and concern, there has been, a lot of, let's say, people have been very anxious to get supplies of N95s to wear all the time, but we just want to really emphasize that N95 shortages do continue to persist. The supply chain has not recovered for N95s. It has for other items, but not respirators. So it's still very important to preserve them for high-risk procedures to protect healthcare workers most at risk. So also wanted to just reiterate that the use of eye protection and masks for all patient encounters, in addition to universal patient source control, and actually even without universal source control, can protect from inadvertent asymptomatic exposures, which is why that is part of the recommendations. And the World Health Organization infection control guidance also endorses droplet precautions for most COVID care, and again, the N95 respirators for aerosol generating procedures. And several other countries also adhere to these guidance, and also multiple states have endorsed these recommendations as well. Next slide. And just again, the Infectious Disease Society of America and also the Society of Critical Care Medicine and their surviving sepsis guidance also recommend using surgical masks or N95s for the routine care of patients with COVID-19. And again, N95s for the aerosol generating procedures. And so the CDC also recently released a new updated guidance on for when we are going into more of a containment stance, guidance on assessing healthcare worker exposure risk. So kind of if they're a patient, say, had been in a facility that then subsequently gets diagnosed with COVID-19, when one is going about trying to find exposure, contact investigation and looking for exposed people, if a healthcare worker was wearing a face mask and eye protection during an encounter with a patient who has COVID-19, that is not considered an exposure, and therefore that would not require a furlough or quarantine, whether or not the patient was wearing a mask. So that's another sort of reasoning for this new guidance about the use of eye protection and masks. So, it's really just as we're kind of starting to go into a different phase, we obviously all want to prevent having to quarantine or furlough or cause unnecessary exposures to our staff. And again, this, just to be clear, does not apply to aerosol generating procedures. The full recommended PPE applies here. Otherwise, if you are not wearing full recommended PPE for aerosol generating procedures, you could be at risk for a furlough if it was with a known COVID patient. Just to again reiterate, what are the scenarios when you definitely need an N95 is when performing aerosol generating procedures, and also we recommend it when in areas where there is care for patients who are critically ill. So that the rationale there is that patients with critical illness could rapidly decompensate and very quickly require an aerosol generating procedure, or are often receiving intermittently aerosol generating procedures. So it's best easiest just to be wearing an N95 in those care areas. So commonly performed medical procedures, just to list off the ones that we would consider higher risk, include open airway suctioning, sputum induction, CPR, endotracheal intubation and extubation, use of BiPAP or CPAPs, bronchoscopies, manual ventilation, and there's also limited data suggested that nebulizer administration, which is of course really relevant in outpatient settings, and also administration of high flow oxygen through nasal cannula or mask may also produce infectious aerosols and should be used with a N95 respirator for protection for any of these. Next slide. And of course, I just want to reiterate, PPE is not a panacea. So just because, you have your face shield and everything else and your mask and everything else on, that is only one part of an overall program that is designed to keep healthcare workers and staff safe. So other interventions that are essential include rapid identification of symptomatic patients through triage, screening at the door or through the phone before a visit, and making sure that these patients are quickly masked and separated from others to avoid exposures. The use of source control, meaning masking these universal source control recommendations where everybody is wearing a face covering in a healthcare setting, at least at this point in the pandemic. Strict adherence to respiratory and hand hygiene practices is huge, key, and essential. And also training staff on the correct use of PPE, and again, rigorous attention to environmental cleaning and disinfection protocols of surfaces and equipment with appropriate FDA-approved cleaning products for COVID-19. Next slide. Oh, go back. And this is just a plug for how important infection control training is. Of course, it's relates to PPE, but everything else we just talked about. So all staff in your facility should receive job-specific or task-specific education. That includes your administrative staff, security, environmental services, cleaning staff, et cetera. It should be job-specific on what they're doing, and training in general should be given on preventing the spread of COVID-19. If you have given it in the last year, great, but as things are starting to reopen up, if you haven't done a refresher training recently, now is a really good time. So also, of course, recommend training. Most important, though, is competency-based training in how to use PPE safely. especially doffing procedures, because that is the highest risk time where you can contaminate yourself. So it's very important that staff know how to do it deliberately and correctly every time. And I just really wanted to point out, this is actually, I think, a really great study that was done, came out in 2016, and this was looking at, this was a study that was done in a hospital cohort of healthcare workers that had been exposed to 17 patients over a series of couple months to MERS-CoV. And then they went back into the retrospective analysis looking at seropositivity in potentially exposed healthcare workers and looked at certain risk factors through questionnaires. And the analysis, so they did a subgroup analysis looking at N95 and mask use, so two different subgroups, and this was multivariate analysis, and this showed that participation in infection control training on the prevention of MERS had a significant protective effect in both groups, so face mask and N95 sub-analysis groups, and it was a strong and significant protective effect, as you can see. So, next slide. And just another, shout for other important interventions besides PPE is engineering control. So these are interventions that can minimize patient and staff exposure and face-to-face contact with potential infected patients. And these are things that you've kind of probably been hearing a lot about and maybe even already implementing, which would be things like physical barriers, like plexiglass sneeze guards at your registration and triage areas. Other physical barriers are partitions to guide patients through triage areas or in the waiting rooms. Really taking a look with your an engineering specialist and make sure that your air handling systems are optimized with appropriate directionality of flow. So air rate exchange and your filtration system. So just a good opportunity to kind of take a look at that and see if there's anything that can be optimized. And if you are, a facility that does perform things like nebulizer treatment and other potential aerosol generating procedures, and you don't have a negative pressure room in your facility, you could look at the use of a portable HEPA filter to potentially create a temporary relative negative pressure space. And there's guidance on how to do that in our references. Next slide. And so, over the last several months, we've seen shortages in many different supply of PPE items. And, if there is a subsequent wave, we expect similar strain to occur again. So, we still would recommend PPE conservation strategies to be in place. So that would include things like providing training to your staff on, what PPE is appropriate to use when, so they're not unnecessarily using or wasting supplies when they don't need it. Make sure you're screening patients for symptoms, try and screen them even before their appointments. And if somebody has signs of acute respiratory illness, see if it's appropriate to evaluate them by telehealth. And maybe just have them come in just very briefly for a testing visit, things like that. So that would help reduce the amount of people that would need to use PPE for such visits. Also, if you do have these patients in your facility that may be suspicious for COVID-like illness, limit the amount of staff that enter the room of these patients. So, for example, have the primary clinician do the vitals themselves instead of having, additional staff come in and doing things like that with intake questions. And also consider having teams that are dedicated to COVID-19 type visits or sick visits, and potentially have designated hours for sick visits. And that just kind of helps consolidate and reduce the amount of staff who would need to use PPE, especially if you're implementing reuse and extended use policies, which we'll talk about in the next slide. And of course, continue to implement measures that will secure and control your PPE supplies, meaning, probably now is not the time to have boxes of face masks out in the waiting rooms for patients. Just make sure your staff knows when to offer appropriate PPE, et cetera. Next slide. And so I just briefly want to talk about contingency and crisis strategies. So, this is kind of a continuum that we've had to deal with over the last couple months in light of our recent shortages. So there are 3 general levels used to describe surge capacity and prioritizing measures to conserve PPE supplies as part of the continuum of care. So conventional capacity is, that's your day-to-day routine standards of care. Contingency capacity includes procedures and supplies are not consistent with daily standard practices, but are functionally equivalent and probably wouldn't have a significant impact on healthcare worker safety. And crisis capacity is really when you are totally in catastrophic disaster, catastrophic shortages, you are completely out of particular items, and you have to implement adaptive procedures and use supplies that are not commensurate with conventional U.S. standards of care, but provides the best level of care that you can in the context of a disaster. Next slide. And so one contingency capacity is the extended use of PPE, which is wearing the same PPE item for repeated encounters with patients without removing it. So, for example, eye protection, face masks, and N95s are very appropriate for extended use throughout a shift. We just would recommend that you should consider those items contaminated, so avoid as much as possible touching the PPE item to reduce self-contamination risk. And gowns can also be considered for extended use, generally just if you are seeing a cohort of possible or confirmed patients with COVID-19. So, for example, you do have those thick clinic hours and you can go from room to room. You could potentially use extended use of your gown, but you wouldn't want to wear a used gown outside of the patient care area. So you would, of course, take it off before you go to the break room or the charting areas if it's separate from the patient care area. And N95s, for N95s, we generally recommend extended use over reuse, but of course, in reality of shortages, you may have to practice both. But extended use over reuse helps reduce the risk of self-contamination from repeated donnings, putting it back on. And also fit can, the more times you take on and off a N95 respirator, the fit can start to become compromised, particularly after more than 5 times of use. The reliability of fit goes down significantly. And gloves are not recommended for extended use or reuse. Next slide. And reuse of PPE. So this is starting to get more into the crisis, contingency to crisis. The reuse of PPE is using the same PPE item for multiple encounters with patients, but doffing between encounters. So eye protection, goggles, and face shields are actually really amenable to reuse because they're easy to disinfect. And we generally recommend an alcohol-based disinfecting product to reduce kind of buildup and might reduce visibility. Face masks are certainly reusable if they're not visibly soiled, damaged, wet, or hard to breathe through. If the face mask was used for the care of confirmed or suspect COVID-19 patients, you would probably want to consider the outer surface of the mask contaminated. And so you would want to, in that case, fold it up. So the outside surface is inward and stored in a clean place in between uses. And N95 respirators, of course, you want to, again, consider it contaminated. So don and doff very carefully with scrupulous hand hygiene and perform a seal check every time you put it back on. And if you Google performing an N95 seal check, you can get some good videos on that from NIOSH on how to do that. And in between uses, you want to store them in clean, breathable containers, such as a paper bag. Even better if it has a handle, and then you can just hang it by the straps with the handle. And one strategy that we have recommended for kind of if you don't have a fancy decontamination system and you are in an environment where you require regular use of N95 respirators, is to take a supply of 5 masks and rotate them every day. So every 5 days, you're rotating through a series of 5 masks. And you store on the off days, you store them in their paper bags in a safe area. And that gives, 3 days plus for any potential viable virus to die off. So by the time you kind of use the same mask again in 5 days later, then it wouldn't consider to be significantly contaminated and safer for reuse. And for gowns, for reusable, for reusability, we would say generally just reusable cloth gowns are appropriate. The disposable isolation gowns aren't great for reuse, just because they're the straps easily break when you're taking them off, and they're not very sturdy, so generally not recommended for reuse if you can help it. Next slide. And just when you're really into crisis mode, some substitutes for common PPE items. So, some N95 alternatives, especially if you're working in a high-risk unit like a MICU or an ED. You might want to consider something reusable like an elastomeric respirator, which are in this picture to the right, that are reusable and really great alternatives if you're somebody that requires regular use of N95s or respirators. Also, there's certainly, and we'll talk about this on the next slide, the option for imported respirators that are not NIOSH approved. And some isolation gown alternatives include things like reusable patient cloth gowns, or reusable, other reusable gowns, disposable aprons or lab coats. Those are all certainly alternatives. And you can see the link at the bottom is to some other recommendations if you're short on gowns. And face masks alternative, and this is really absolute crisis. If no supplies are available, you can consider a face cloth covering with a face shield over it to protect against contamination. Next slide. And this is just, can you play the video? Yeah. This is, I just love this because it's a very visual representation of why I am so much more of a fan of face shields over goggles. Is just, this is a simulated aerosol being expelled onto a face shield. So just imagine if you had goggles and you were wearing a mask, all of that aerosol would be spread all over and contaminating other surfaces of your face and especially your mask. So especially if you're reusing or extending use of your PPE, I highly recommend the use of face shields. Next slide. And just one last slide on the use of imported respirators. KN95s in particular came up a lot during the surge. And so just wanted to say a quick word about it. So on March 24th, 2020, there was an emergency use authorization put out for the duration of the federal public health emergency for the use of these imported non-NIOSH approved respirators that are manufactured in other countries that have NIOSH equivalent standards. So there's a list of several countries, and there's a link that will be on the slides for that. And then also in another separate category that's treated kind of separately are KN95s, which are specifically manufactured in China. They're treated a bit differently because there has been so many issues throughout the past several months with counterfeit products and quality questions where testing of certain masks have not stood up to what their claimed filtration rates are. So if you are thinking about purchasing KN95s in particular, you should really make sure that you are checking the current list, which changes periodically. So make sure you're checking the FDA website for the most up-to-date list of approved made in China KN95s before you invest in purchasing them. And just, this is really important that, even if you're buying these, you still should be doing fit testing on them just like you would for an N95 to make sure that you have an appropriate fit. All right, and I think that's it for us. Next slide is, oh, sorry. And then just thinking about forward planning. So this is a nice segue to our next presenter about calculating your burn rates. So thinking about things that may increase your use of PPE in the coming several months. So there is Some of you may already be experiencing this, but certainly a potential for reopening surge as we are going into phase 1 and 2. More people will be trying to, again, seek care in person. So you could have a higher amount of demand than you have had in a while. And also, of course, there is something that we hope doesn't happen, but are certainly anticipating could happen is a wave 2 of COVID-19. We're particularly worried about that for the fall and winter, but also just given, now that we're going into easing of some mitigation measures, we've had recent mass gatherings. We're watching very closely for a second wave, but you should be kind of thinking of that as you're working through your supply needs and purchasing. And also, again, just thinking through for influenza respiratory viral season, it's going to be, you're going to have a significantly higher burn rate than you have in previous years because we will surely be continuing the recommendation for universal source control for mask use. And also, it's going to be incredibly difficult to differentiate between flu, RSV, COVID-19, so you will have to use higher levels of PPE for a lot of these visits. So just really heavily encourage you to take that into account with your planning. And I think that's it for me. The next slides have some resources that will be available when we post the slides for your reference. And thank you very much.
Thanks, Mary. All right, I'm going to hand over to Jay to chat about calculating a burn rate.
Thank you so much. And this will be relatively quick, but before I get started, I just want to thank everybody at OEM for all their hard and wonderful work that they've done on helping community-based organizations get PPE over this crisis. We at MJHS really benefited from the help of OEM, so we really appreciate all of their both support and guidance, and in addition to actual material support that they gave us. Just to give everybody a little bit of background, my name is Jay Gormley. I'm the Chief Strategy Officer for MJHS. I think most of you know that MJHS is a large integrated post-acute system based in Brooklyn, but covering all 5 boroughs, plus Nassau, Westchester, and a little bit in Suffolk and upstate. We operate nursing homes, home care, hospice, and we also have some housing, and then a large part of what we do is in the insurance side, the MLTCP and a Medicare Advantage plan. So I'm happy to talk about this. Interestingly enough, this is not my area of expertise. I'm a strategy person, but like everybody during this crisis, I sort of got thrown into materials management. And one of the things is when I start to figure out how to do all this, the first thing I did is I went in the CDC. So the CDC has the granddaddy burn rate calculator. If you click on the link when it goes out, this will give you to a very complicated spreadsheet. And then if you have all of the data that you need to put into that spreadsheet, it will put you out a wonderful burn rate that is incredibly precise. I don't know how accurate it will be, but it'll be very precise. And so what I mean by that is that one of the big things about burn rates, it has to do with what you can put in is just as important as what comes out. So it's your core data that is really the key part in doing a burn rate. So the 3 things you really need to know before you even start this is how many staff you have, how many patients you have, and how much stuff you're starting with. Those are the 3 basic things you need. And then you can do the burn rate one of 2 ways. The first easiest way is the historical use method. What that means is that you just say, okay, in the last month, how much PPE did I buy on the 1st of May? How much did I use by the end of May? I divide by 30 or 31 days, or by 4 weeks or 4.5 weeks, however I know, it really depends on the type of facility you are and your shifts, what you divide by, and then it pops out a burn rate. The problem with that is that this has been a crisis that has changed and moved. The recommendations on what PPE you need to use have changed and moved. The availability of PPE has moved. If you're reusing PPE, if it's a crisis, if you're conserving PPE, all these things move around. So the best way is what I would call the planned use way. And so what you should do is you should get the PPE plan from your infection control folks. And if you don't have infection control folks, you should really look through the guidance that comes from New York City, and they will give you some thoughts about how much PPE you should be using. Then what you should do is you should sit down and figure out what numerator you're going to use. What I mean by numerator, what variable are you going to use to drive PPE? And it really depends on the kind of agency or program that you are. For some agencies, congregate living agencies primarily, so I'm talking about adult homes, nursing homes, assisted livings, ALPS, folks who are providing housing services but have some sort of medical component through a licensed agency or something, that's really actually going to be driven more by staff, not really by clients, because you're going to need the PPE that you need to, especially if you're cohorting COVID patients. It doesn't really matter how many COVID patients you have in one unit. It's the staff are all going to need the same amount of PPE. If you're in the community and you're visiting clients, and especially if if you need to change PPE between clients, and again, it depends on the type of PPE, like gloves, obviously you have to change. Others, and again, it's really a mix. Then you really do sort of a client-driven model here. And so you should sit down with your plan and figure out how much you're going to need and then multiply out. And what you're hearing from me is there's a lot of variables here, because this is at times a little more art than science. What we did at MGHS is we did a comparison. So we looked at our historical use. At our historical use, that was our baseline PPE for all of our different various agencies and facilities. And so we just looked at our normal flu season and used that as the base amount that we were going to use. We then, on top of that, added in extra PPE that we needed to do as the COVID cases came in. And then around halfway through the crisis, we ended up being recommended and needing to impose certain conservation measures. So I sat down with our infection control folks, and we also had the benefit of having a physician who works on our palliative care department, but ended up working with our infection control. And he sat down and we spent a couple hours figuring out exactly in an ideal world how much each nurse, home health aide, social worker, et cetera, aid in the facilities would use, and then we just multiplied it out. And we were close. But the one thing I will tell you about any kind of a burn rate calculation is that you will probably be a little wrong. So it's important to always check and do a feedback loop of what you're actually using. And we usually do that checking on a weekly basis. And the last thing I will say is that one of the things that we were supplying to is a home visiting NP/ND practice, which is part of our system. And we were humming along, and I was really, really pleased at how well my estimates were coming up against actual use rates. And all of a sudden, over the weekend, all kinds of stuff flew out the shelves, and I didn't understand. It didn't make any sense to me. And it was because these particular providers were servicing folks out in Suffolk. They were 100% not using any OEM New York City supplies. I'm going to be clear on that. But using the supplies that we had purchased, people out in Suffolk, and what they were doing is the manager drove in, took a whole bunch of PPE at once, and then drove it back out. And I hadn't calculated that in. So these sort of exogenous events or things that might happen that makes your supply a little lumpy, you need to try to factor those in. So again, that's really the story on burn rates. I think that the best way, again, is to think about it. There's no one fit all solution for your agency. But doing a planned method on top of historical use. And then the last bit is there's nothing wrong with putting a 5 to 10% factor on top of it for wastage or for accidents or for just a little fudge factor for yourself. I mean, you don't want to double it. You don't want to go over the top with that, but it's always good to build in as best you can a little bit of extra use. Especially since most of these supplies don't go bad, so that you can use them over the course of this crisis, which unfortunately I think will be a long-term crisis. And as supplies have freed up, we've been able to stockpile a little, but again, we still are having problems, and you are all probably having problems, and this is a good transition to the next part of the presentation to talk about purchasing, on getting our hands on N95s and also gloves actually becoming a bit of a problem for us. So that's what I have so far, and I want to thank everybody for their time, and I look forward to questions at the end.
Thanks, Jay. I'm going to hand it on to Dave, who's going to talk through tips and best practices on purchasing PPE.
All right, thanks, Jenny. And thanks, Jay, although I would want to point out that we're with the Department of Health, not OEM, just so to make that clear. So I'm here, I'm sure many of you are probably more specialized in this type of stuff than I am, but I am here to just give an overview for those of you who aren't about the supply chain, the medical supply chain, and some things that we've learned over the few years that we've been involved in both purchasing PPE and our work with sort of monitoring the distributor supply levels in different types of emergencies, even, when there are pharmaceutical shortages. And I think many of you probably have remember experiencing the saline shortages of the last few years and stuff like that. So next slide, Jenny. I just want to, the overview is basically, I think most of you know this, we have manufacturers, and then depending upon the item, of course, I think this has really been an issue since this pandemic has affected the global supply chain. Everyone needed the PPE, including the countries where it was manufactured, and it became particularly acute as supply chains became more and more lean and manufacturing became more and more, there's always that cost driver to get products for the cheapest possible price and maintain the lowest level of inventory, all those cost settings, all those things kind of decrease resiliency. So as you know, and you've probably read, the majority of the PPE that we use is produced overseas in countries like China, Turkey, and Malaysia. China, of course, being the source of the outbreak. So it immediately sort of turned the PPE supply chain on its head, more so than if it had emerged somewhere else where China wasn't affected. So China and other countries actually shut down some of their exports and restricted exports so that they could focus PPE on their own outbreaks. There is limited manufacturing in the U.S., and I think there have been some news about that, about various manufacturers sort of trying to raise the alarm that this is almost a national security issue. But it remains limited, although it is increasing, and this is part of the rebound of the supply chain as it reacts to this, is that manufacturing, local manufacturing, even large-scale manufacturing is actually increasing in the U.S. as a result. And, even if PPE is manufactured, I think in the U.S., I think a lot of people, when Hurricane Maria hit Puerto Rico, there was a lot of medical material being manufactured in Puerto Rico, and that was one of the sources of the saline shortage of the year after Maria, although previously there had been shortages, and I think of saline, and then I think most people are aware of the shortages of doxycycline and things like that in the past, where it skyrocketed in price around 2011, went up by like 1,000% in price. So there's a sort of a weakness in our supply chain as it is because we're dependent upon manufacturers primarily outside of the country. Now you can go ahead. And then, so once it's manufactured, of course, most of the supply goes to these enormous distributors. Most of these are very familiar to, there's sort of almost household names in the healthcare world, Owens & Minor, Cardinal, Medline, McKesson, Henry Schein, Concordance, and some others. That's pretty much the top, those are the largest of the large. And there's been a significant amount of consolidation over the last probably 8 to 10 years where there was a smaller one called Kinray that was absorbed, I believe, into Cardinal, and there's been a lot of acquisition. Concordance bought MMS, Caligor, all these, this consolidation. But there still remain quite a few smaller distributors who tend to serve smaller sort of groups or specialty practices and things like that. And they either purchase directly from manufacturers or from the larger distributors. And the largest distributors like Owens & Minor actually own some manufacturing lines. You'll see a lot of Medline, also Cardinal, where they'll actually manufacture it and brand it with their own brand name. But again, most of it is actually separate. Most of the time the distributors are actually purchasing from these manufacturers. You can make that. So we're not here to sort of gear this talk towards the large scale entities like some of the hospital networks, because as you know, they can sometimes purchase directly from manufacturers. They can actually import on their own if they're buying in quantities that large, or they participate in group purchasing organizations where they pool their demand so they become an even bigger client and can sort of, even some smaller clients can get the same pricing and same access to manufacturing and distribution that very large organizations has. Unfortunately, most smaller entities don't have access to these types of opportunities, like buying straight from a factory in China or participating in an enormous GPO. And we think associations you may want to talk to your associations, and some associations have GPOs or consultants that help work with their clients. And they may be able to assist with the development of GPOs. We can't set up a group purchasing organization because of liability and other legal concerns about favoritism towards certain clients. However, we have at least, and we acknowledge, as Jay said, that it's still pretty tough out there, and the N95 supply in particular, we've seen some residual problems with glove supply and things like that. And I can say it's not easy for anyone right now. So we're just trying to put together some information, and in case you didn't know about this, and resources for you if you're still having difficulty. So first off, we did come up with sort of an informal list of suppliers that we learned about through our work, either from some of you or just some of the research that we've done. And we meant to change this word to, it's not exhaustive. So it's an informal list. We don't endorse anyone on the list. We can't guarantee that they'll provide supplies. There's a sort of a disclaimer on that document. But if you go to nyc.gov and then just search for medical supply companies, I just tested it, it will be the first document that pops up. So we hope that will help you. It's a list of about 18 to 20 distributors, both large and small, large like the Owens & Minor, as well as some smaller ones. And we hope that will help you out. We're always willing to add additional suppliers. So if there's someone on there that you know of, please type it into the chat and we'll look it up and add it to that list. So we want to give people as many options as possible. The other thing is that we learned in some of our work is that many times the suppliers that you buy your vaccine, if you vaccinate in your facility, vaccine suppliers can supply at least some of your PPE, things like gloves. They're often available through the vaccine companies. And then finally, this is also on that sheet, the Medical Society of the State of New York, Disney has arranged for PPE to be available. So if you go to the MSNY.org website, on the right side of the page, if you're a member of MSNY, on the right side of the page, you'll see a box that says members access your PPE here. Again, they're sourcing it from similar distributors, so you'll see some language there saying they can't guarantee that it's going to arrive. There still may be some delays and things like that. It's another option you may want to take advantage of. And then I think most of you are probably aware of this, but I've found myself explaining this concept quite a bit. So there is, what happens in times of shortage is that distributors and others put their customers on allocations. So when you're on allocation, it means you won't get if you're ordering 200% of what you ordered last year at the same time, and the items on allocation, they will put you on 120% allocation, 150%, which means they'll only fill up to 150% of what you ordered the year before. During this period, we actually saw things go way below 100%, down to, in some cases, 40%, which means even though you needed 200% of what you were ordering last year, they were only going to give you 40% of what you ordered in the same period. So it was, I think all of us were surprised by how deep the allocations went this year. It was bad. We were aware of that. And I think at one point, speaking to some of the distributors, and 8,000 items, not just PPE, but 8,000 items were placed on allocation according to one of our distributors from their manufacturers and from the larger distributors that are going down to them. And that was in February, which was very, we saw this coming, although it was kind of one of those things where you see it coming and there really wasn't much we could do about it at the time. So I think, we probably, and this goes for the CDC too, we should have pushed out messaging about conservation and crisis standards before we got to the crisis and the PPE that was already in the supply chain. And I think that's what Mary described earlier, is really being aware of conservation strategies, even as the supply chain recovers, because there is always that risk of the second wave that could put us similar, in a similar straits, although with the additional manufacturing capacity we're hoping, and the fact that a lot of people are stockpiling now, even now, are that we may be able to ride the next wave without the same kind of severe impacts on the supply chain as we saw in the last few months. But just so you know, we have been in touch with the distributors. Hundreds and hundreds of items, thousands of items have come off allocations, and they literally come off every week. So we're seeing sort of a day-by-day recovery of the supply chain as manufacturing kicks up, as demand drops. Although we are seeing demand isn't dropping as much because of the need for PPE by more and more people who wouldn't normally be purchasing these items. So one of the points I want to make, though, is that in these times, distributors and sellers that you don't have a relationship with already will almost never establish a new, develop a new customer relationship. So if you go to the next slide, Jenny, I think one of the things we would advise is really particularly in times when we're not in shortage, establish some type of purchasing relationship with as many different suppliers as possible, so that you won't be one of those people who are new to the suppliers and just denied outright. Doesn't guarantee anything, but the more people you have, the more entities you have purchasing relationships, the better, the more likely you're going to be able to at least get a portion of what you need during the emergency. And then I think that we have seen some cases where people have formed very informal GPOs, group purchasing organizations. Is particularly effective, when you're going to someone, then they say, well, we'll only accept a minimum of X, 10,000 of an item order, and you only need 1,000. If you can get together with some other organizations and facilities and maybe put in a joint order, that can be a good way. And then finally, and I talked to my own primary care provider, and he was sourcing on Amazon, and although there you do get into the price gouging and the quality, because the demand there on those platforms is really driving the price. And I think when we wrote this slide, we were going to have like an open discussion, but I don't think we can do that with number one, given the time left. So we'll skip that, and I will back to Jenny, I guess.
Great, thank you. So we've got a little bit of time left, but I think, maybe we've got our panelists can stay on a little bit longer, but we're definitely interested in here and happy to answer any questions. So the best way for you to ask questions is to go ahead and type them into the chat box. I see one here. This looks like a question for Mary. Is a gown required for medical assistance without or with minimal patient contact?
I actually answered that question directly, but for the audience. So if you're in very minimal to no contact with the patient, the risk is extremely low, and you probably are fine without a gown. We do recommend, to have a change of clothes that you can change out of your, can change into after the end of your shift. Just, then you can take your clothes that you worked in home and wash them. But you should be okay without a gown if you're not in close contact.
Great. I've got another one, Mary, that looks like this could be. Where do we find resources for fit testing? I'm guessing this is specific to N95s.
Yeah, this has been something that I think a lot of facilities are struggling with that don't have, in peacetime, a respiratory protection program or respiratory safety program. But, there are just-in-time sort of emergency options. There are some vendors that are doing it, and there are occupational health clinics that can do fit testing for you. It's just really important to reiterate that you need to be fit tested on the mask you're actually going to be using, or the respirator you're actually going to be using. So make sure, what you can source is what you're fit tested on. But there are also, options for, there's online trainings offered on the OSHA website. So, and then you can purchase qualitative test kits. So that could be a potential just-in-time option. But if you're going that route, you should probably start looking into just establishing a formal respiratory protection program at your facility.
Great. Any other questions? I'll give folks another minute to sort of type in if they have follow-ups.
There is a good question about guidance on glove use. So, you know, gloves are for contact precautions. You know, they're most important if you're talking about protecting yourself from bloodborne infections, which, you know, COVID-19 is not bloodborne. So it's more about, you know, wearing gloves to prevent self-contamination to your mucosal membranes. So, you know, we do recommend gloves for the care of a COVID patient or COVID-like illness. But, you know, really at the end of the day, if you're practicing very good, rigorous hand hygiene, that's, you know, that's generally fine enough unless you're working with, you know, have a potential exposure to body fluids or going to be in, you know, prolonged close physical contact, you know, otherwise with patients. But, you know, the most important thing is hand hygiene, really.
Great. Any other, trying to look back through the chat box and see if we missed any. Any other questions from participants?
So Jenny, there was a good question about asking for a little more elaboration on the calculation ratio. That was for the calculating your burn rate.
Great. Jay, you want to jump on in?
Absolutely. Sorry, I had to find my mute button. Yeah, the best way to do it is that the historical use is you should take what you use for a week in a particular type of PPE, divide by 7, and that then gives you your burn rate for the day. Then you can then multiply that back. The other way to do it on the calculated burn rate is to do it by taking what you think you'll use in a day and then multiplying it out by 7. So the best way to do that for a shift, for example, is that if you think, all right, someone's going to use 1 N95 per shift, take your numbers of shifts, 3 shifts, then multiply that by 7 times your, you know, your standard rate. That's the best way to do it. But again, there has to be variance based on the type of PPE and the type of facility. So I can't give you just a simple rule of thumb.
Great, thanks. Are there any other ones that we missed? Mary, you have a good eye. Did I miss other ones? Doesn't look like it. Great. With that, I guess we'll go ahead and wrap up. We're just minutes over here. We're going to post our slides online. You'll be able to find them in the coming days in our provider resources section of our website, city.gov/health. And I want to do a really big thank you to all of our presenters today. Thank you so much for your time thinking about this and sharing your own expertise and resources. And that's it. So thanks, everybody.